In the previous lecture, we simplified the classification of shock using a water supply system analogy, where we discussed that shock is simply a state of inadequate tissue perfusion, in which the delivery of oxygen and nutrients to tissues becomes insufficient to meet cellular demands. Regardless of whether the cause is hypovolemic, cardiogenic, obstructive, or distributive shock, the final outcome is essentially the same: reduced oxygen and nutrient delivery to the cells. But when tissue perfusion starts to fall, the body does not simply remain silent. It immediately activates a series of compensatory mechanisms to maintain blood pressure and preserve blood flow to vital organs. Initially, these responses can be quite effective. However, if the underlying cause of shock is not corrected, these compensatory mechanisms eventually fail, leading to progressive cellular injury, organ dysfunction, and ultimately irreversible damage. So in this lecture, we will follow the progression of shock through its three major stages: compensated shock, decompensated or progressive shock, and irreversible shock. These stages can be seen in virtually all types of shock, whether hypovolemic, cardiogenic, obstructive, or distributive. Along the way, we will see exactly what happens inside the cells when oxygen delivery becomes inadequate, and how these cellular events drive the progression from reversible injury to multi-organ failure. The first stage is the initial or compensated stage of shock, also known as the reversible stage. At this stage, due to any cause of shock, there is reduces cardiac output and tissue perfusion, leading to decreased oxygen delivery to the cells. However, the body immediately responds by activating a variety of neural, hormonal, and chemical compensatory mechanisms. These mechanisms work together to maintain cardiac output, blood pressure, and blood flow to vital organs such as the heart and brain. As a result, although shock reduces tissue perfusion and would eventually lead to a fall in blood pressure, but the body's compensatory mechanisms initially work to maintain blood pressure at or near normal levels. Therefore, a patient can already be in shock even when the blood pressure appears normal. This is why, during the compensated stage, patients often show few or only subtle signs and symptoms despite ongoing tissue hypoperfusion. In fact, if a patient's usual blood pressure is known, a drop of approximately 30 millimeters of mercury or more below their normal value may be an early indicator of hypoperfusion, even if the measured blood pressure still falls within the normal range. Suppose a patient whose normal blood pressure is 150 over 90 millimeters of mercury due to tissue hypoperfusion falls to 120 over 80 millimeters of mercury. So there is a significant 30 millimeters of mercury drop from their baseline. Although this is generally considered a normal blood pressure, for this particular patient, it may indicate that tissue perfusion is already being compromised. Therefore, when assessing a patient for shock, it is important to compare the current blood pressure with the patient's usual baseline whenever possible. Now let's discuss the neural compensatory response, which is the fastest compensatory mechanism activated during shock. Its main purpose is to maintain blood pressure and tissue perfusion, and it is primarily mediated by the vasomotor center in the medulla oblongata. The moment blood pressure starts falling, specialized pressure sensors called baroreceptors in the carotid arteries and aorta detect the reduced stretch caused by the drop in blood pressure. These receptors then send fewer impulses through the afferent fibers of the glossopharyngeal nerve from the carotid sinus and the vagus nerve from the aortic arch to the nucleus tractus solitarius in the medulla. The nucleus tractus solitarius processes this information and stimulates the vasomotor center, which increases sympathetic nervous system activity while reducing parasympathetic activity. As a result, norepinephrine and epinephrine are released, causing tachycardia, increased myocardial contractility, arteriolar vasoconstriction, and venoconstriction. These responses help maintain cardiac output, increase systemic vascular resistance, and improve venous return, thereby supporting blood pressure despite reduced circulating volume. Next one is chemoreceptors, which monitor oxygen levels, carbon dioxide levels, and blood pH. When oxygen levels fall, carbon dioxide levels rise or acidosis develops. Chemoreceptors in the carotid and aortic bodies are stimulated. These receptors then send signals to the medulla. Again stimulate the nucleus tractus solitarius and vasomotor center, reinforcing sympathetic outflow. Together, these neural mechanisms act within seconds to maintain blood pressure and preserve blood flow to vital organs such as the brain and heart, even though overall tissue perfusion may already be reduced. Now, after the neural mechanisms, let's move on to the hormonal compensatory mechanisms. One of the first hormonal responses to shock involves the adrenal glands. When the sympathetic nervous system is activated, it stimulates the adrenal medulla to release the catecholamines, epinephrine and norepinephrine, into the bloodstream. These hormones reinforce and prolong the effects of sympathetic stimulation, helping the body maintain blood pressure and tissue perfusion. During the early stages of shock, venoconstriction occurs before significant arterial constriction. This is particularly important because most of the body's blood volume is stored within the veins, which are often referred to as capacitance vessels. Therefore, by constricting the veins, the body can push some of this stored blood back toward the heart, increasing venous return, preload, and ultimately cardiac output. In many cases, this response may temporarily help restore effective circulating volume and maintain tissue perfusion. Another important hormonal compensatory mechanism activated during shock is the renin-angiotensin-aldosterone system. When the kidneys detect reduced blood flow and hypoperfusion or receive signals from the sympathetic nervous system, they respond by releasing an enzyme called renin. Renin then acts on angiotensinogen, a protein produced by the liver, converting it into angiotensin 1. As the blood circulates through the lungs, angiotensin converting enzyme converts angiotensin 1 into angiotensin 2. Now, angiotensin 2 is a very powerful vasoconstrictor. Therefore, it causes blood vessels to constrict, helping to increase systemic vascular resistance and maintain blood pressure. In addition, angiotensin 2 stimulates the adrenal cortex to release aldosterone. Aldosterone acts on the kidneys, causing them to retain sodium and excrete potassium. Since water follows sodium, this results in increased water retention and a reduction in urinary output. Consequently, blood volume increases, venous return improves, and blood pressure is further supported. Therefore, the overall purpose of the RAAS is to conserve fluid, increase circulating blood volume, promote vasoconstriction, and ultimately help maintain tissue perfusion during shock. Another important hormonal response during shock involves antidiuretic hormone, also known as vasopressin. ADH is produced in the hypothalamus and stored in the posterior pituitary gland. It is released when the body detects hypovolemia or an increase in blood osmolality through signals from receptors located in the carotid bodies, atria, and hypothalamic osmoreceptors. Once released, ADH acts on the kidneys, particularly the distal renal tubules, where it promotes water reabsorption and reduces urinary output. As a result, the body conserves water, helping to maintain circulating blood volume during periods of hypoperfusion. In addition to its effects on the kidneys, ADH is also a potent vasoconstrictor. Therefore, it causes blood vessels to constrict, which helps maintain mean arterial pressure and supports tissue perfusion. In addition to the major compensatory mechanisms we have discussed, several other hormones and chemical mediators also play important roles during shock. One example is adrenocorticotropic hormone. During periods of severe stress or trauma, signals from various parts of the brain stimulate the hypothalamus, which in turn triggers the anterior pituitary gland to release ACTH. ACTH then stimulates the adrenal cortex to produce glucocorticoids, particularly cortisol. Cortisol helps the body cope with stress by increasing glucose production in the liver and kidneys, thereby ensuring that cells have an adequate energy supply. As a result, patients experiencing shock often develop elevated blood glucose levels. At the same time, the body suppresses less essential functions during stress. For example, the release of gonadotropins is inhibited, which is why prolonged stress can sometimes lead to amenorrhea in women. Lastly, let's discuss the chemical or respiratory compensatory mechanisms that occur during the early stages of shock. As the body redirects blood flow toward vital organs such as the heart and brain during shock, perfusion to other organs, including parts of the lungs, may decrease. Consequently, some alveoli remain ventilated but receive inadequate blood flow, creating a ventilation-perfusion mismatch. To understand this, imagine an alveolus as a bus stop. Oxygen arrives at the alveolus through ventilation. The blood flowing through the pulmonary capillaries acts as the bus that picks up the oxygen. Therefore, efficient gas exchange can occur only when both oxygen and adequate blood flow is present. However, during shock, particularly when cardiac output decreases, pulmonary blood flow also begins to fall. Although the alveoli may continue to receive air normally through ventilation, but there are not enough red blood cells flowing to pick up and transport that oxygen. In other words, ventilation is still occurring, but perfusion is inadequate. This imbalance between ventilation and perfusion is known as a ventilation-perfusion mismatch. Due to this ventilation-perfusion mismatch, oxygen delivery to the tissues begins to decrease, while carbon dioxide starts to accumulate in the blood. As a result, peripheral chemoreceptors located in the carotid and aortic bodies become activated. These receptors detect the falling oxygen levels and rising carbon dioxide levels and send signals to the respiratory center in the medulla. In response, the respiratory center increases the rate and depth of breathing, causing tachypnea and hyperventilation. This compensatory response helps bring more oxygen into the lungs and remove excess carbon dioxide from the body. At the same time, chemoreceptor stimulation also contributes to sympathetic nervous system activation as we discussed above, helping to support cardiac output and tissue perfusion. Therefore, the increased respiratory rate commonly seen during the compensated stage of shock is an important compensatory mechanism aimed at improving oxygenation and minimizing the effects of tissue hypoxia. Therefore, when we look at all of the compensatory mechanisms together, neural, hormonal, and respiratory, their primary goal is to maintain cardiac output, blood pressure, and perfusion to vital organs. As a result, during the compensated or reversible stage of shock, patients typically present with tachycardia, increased myocardial contractility, peripheral vasoconstriction, increased diastolic blood pressure, tachypnea, pale, cool, clammy skin, and decreased gastrointestinal activity, all of which reflect the body's ongoing effort to preserve oxygen delivery to the heart and brain. Now, if the underlying cause of shock is not corrected, the body eventually enters the decompensated or progressive stage of shock. At this point, the compensatory mechanisms that were initially successful in maintaining blood pressure and tissue perfusion begin to fail. As a result, the systolic blood pressure typically starts to fall, often dropping below 100 millimeters of mercury. Consequently, tissue perfusion becomes severely compromised, leading to global hypoperfusion and the onset of organ dysfunction. So, the fundamental problem in the decompensated stage of shock is severely reduced oxygen and nutrients delivery to the cells. As a result, the cells can no longer generate energy efficiently through aerobic metabolism and are forced to switch to anaerobic metabolism. Under normal conditions, glucose is first broken down into pyruvate in the cytoplasm through a process called glycolysis, which does not require oxygen. The pyruvate then enters the mitochondria, where, in the presence of oxygen, it undergoes the Krebs cycle and oxidative phosphorylation. This aerobic pathway is highly efficient and produces approximately 36 molecules of ATP from a single molecule of glucose. However, in decompensated shock, without sufficient oxygen, pyruvate can no longer enter the aerobic pathway and is instead converted into lactic acid through anaerobic metabolism. This pathway generating only about 2 molecules of ATP per glucose molecule, compared with the 36 ATP produced during aerobic metabolism. Consequently, ATP production falls dramatically while lactic acid begins to accumulate within the tissues, leading to metabolic acidosis. This decreased ATP and lactic acidosis further worsen the problem. ATP is required to power numerous cellular processes, but one of its most important roles is maintaining the function of the sodium-potassium ATPase pump. In fact, nearly 70% of a cell's ATP is used to operate this pump. Under normal conditions, these pumps continuously pump sodium out of the cell and potassium into the cell. However, when ATP becomes severely depleted, these ion pumps begin to fail. As a result, sodium accumulates inside the cell while potassium leaks out of the cell. Water follows sodium into the cell by osmosis, causing the cell to swell, a process known as cellular edema. As swelling worsens, cellular functions become progressively impaired, and eventually the cell membrane may rupture, leading to cell death. Simultaneously, the rising lactic acid creates a highly acidic environment, affects other intracellular structures and proteins, including the lysosomes. Normally, lysosomes contain powerful digestive enzymes safely enclosed within a membrane. But this buildup acid damages the membranes of lysosomes. Lysosomal membrane function becomes disrupted, allowing these enzymes to leak into the cell and digest its own components. This further accelerates cellular injury and death. Furthermore, both ATP depletion and lactic acidosis have profound effects on the heart itself. The myocardium requires a continuous supply of ATP to maintain effective contraction. However, as ATP levels fall and acidosis worsens, myocardial contractility becomes progressively depressed. As a result, cardiac output begins to decline, leading to an even greater reduction in oxygen and nutrient delivery to the tissues. This worsening tissue hypoxia forces more cells into anaerobic metabolism, causing further ATP depletion and additional lactic acid accumulation. Consequently, a self-perpetuating vicious cycle develops in which impaired tissue perfusion leads to cellular injury, and cellular injury further impairs tissue perfusion. Unless this cycle is interrupted, progressive cellular dysfunction ultimately culminates in widespread organ failure and death. At the same time, prolonged cellular hypoxia, together with ATP depletion and lactic acidosis, begins to damage the endothelial lining of blood vessels. Injured endothelial cells trigger a localized inflammatory response, leading to the release of various cytokines and inflammatory mediators. These substances increase the permeability of the capillaries, making them abnormally leaky. As a result, fluid and plasma proteins begin to escape from the intravascular space into the surrounding interstitial tissues. Resulting reduces the effective circulating blood volume. With less blood returning to the heart, venous return and cardiac output decrease further, causing an even greater decline in tissue perfusion. Consequently, oxygen delivery to the cells falls even more, worsening cellular hypoxia and accelerating cellular injury and death. As the shock state progresses, blood flow through the microcirculation becomes increasingly sluggish. This slow-moving blood, combined with endothelial injury and the release of procoagulant substances from damaged and dying cells. As a result, numerous microthrombi or tiny blood clots begin to form within the capillary beds throughout the body. This process is known as disseminated intravascular coagulation. These microclots obstruct the already compromised microcirculation, physically blocking what little blood flow remains to the tissues. Consequently, tissue perfusion falls even further, causing more severe ischemia and hypoxia at the cellular level. This leads to additional cellular injury and death. Also, as acidosis becomes more profound, it causes widespread vasodilation and significantly reduces the responsiveness of blood vessels to both endogenous catecholamines and exogenously administered vasopressors. At the same time, ongoing endothelial injury further impairs vascular integrity and regulation. The combination of profound vasodilation and vascular dysfunction causes blood to pool within the peripheral circulation rather than returning efficiently to the heart. As a result, venous return and preload decrease, leading to a further reduction in cardiac output. This additional fall in cardiac output further compromises tissue perfusion and oxygen delivery. So, if we step back and look at the overall picture, the decompensated stage of shock is characterized by a series of self-perpetuating vicious cycles. Reduced tissue perfusion leads to cellular hypoxia, which causes ATP depletion and lactic acidosis. These changes result in cellular swelling, lysosomal rupture, myocardial depression, endothelial injury, capillary leak, microvascular thrombosis, and profound vasodilation. Each of these mechanisms further reduces tissue perfusion, causing even more hypoxia and cellular damage. At this stage, organ dysfunction is already developing. But if the underlying cause of shock is identified and treated aggressively, recovery may still be possible, because a significant proportion of cellular injury remains potentially reversible. However, if shock continues unabated and tissue hypoperfusion persists for a prolonged period, the body eventually enters the irreversible stage of shock, also known as refractory shock. At this point, cellular and organ damage has progressed beyond the threshold of recovery. Extensive cell death has already occurred in multiple organs, and even if blood pressure, cardiac output, and tissue perfusion are restored, the damaged cells can no longer regain their normal function. The heart becomes profoundly depressed and unable to generate adequate cardiac output. The kidneys suffer severe ischemic injury, leading to acute renal failure. The liver loses its ability to perform essential metabolic and detoxification functions, while the lungs develop severe respiratory dysfunction. Simultaneously, widespread endothelial injury, capillary leak, and disseminated intravascular coagulation continue to impair the microcirculation. As a result, oxygen delivery remains inadequate at the tissue level despite attempts at resuscitation. In other words, during irreversible shock, the problem is no longer simply inadequate circulation. The organs themselves have sustained such extensive structural and functional damage that they can no longer recover. This culminates in progressive multi-organ dysfunction syndrome, followed by multi-organ failure and ultimately death. Thus, irreversible shock represents the final stage of the shock continuum, where the vicious cycles of hypoxia, inflammation, cellular injury, and organ dysfunction have become self-sustaining and no longer respond to conventional therapeutic interventions.